Go ahead and get started. Again, this is the Intermountain-led Hospital Engagement Network Affinity call focused on CLABSI prevention today. And today we have Joan Golden from Intermountain Healthcare's Quality and Patient Safety Group presenting the work that group has done on reducing CLABSIs throughout the system. So she'll be going over some of the key elements of that program and specifically focusing on the details of not necessarily what they did, although there will be elements to that, but there's a primary focus on really how they did it, what teams they needed to get involved in, what people to make this program successful. So before we get started there, as we do with all of our Affinity calls, we just wanted to review our current progress, and this is just a simple depiction of kind of how we're doing overall with throughout our network with the 10 patient safety areas that we're charged to focus on. So, of course, today we're focused on CLABSI, and you can see this is actually one of the areas where we've had the most success from our 2011 baseline. We have right now across our network a 60% reduction from 2011. So, applaud to everybody out there for their work and hope to see continued success in that area. You can see in some of our other areas we're not doing so well, specifically potty, we're struggling just as much as everybody across the country is struggling in this area. So we'll continue that on HAI prevention push. And then you can see in our other areas, these orange areas, we're not necessarily at our 40% goal in VTE reduction or SSI, but there have been a national benchmark, high-performing benchmarks established, and our rates are currently below those high-performing benchmarks. So we consider those successes. When we're at such a low rate, we don't expect to see a full 40% reduction, but we do see a little bit of an increase in SSI. So really quickly, I just wanted to take a more in-depth look at the rate we're looking at for the CLABSI, which is ARC PSI 7. So you can see the rate's been bouncing around a little bit, and we haven't really seen a real trend in decreasing rate as of the beginning of 2012, but it's been maintaining a relatively low rate compared to our baseline. And again, you can see here we're at a 60% reduction from that baseline, and this is just some data to go along with that chart there to take a look at kind of what's going on. So the actual numerator you can see here is quite low across the 72 hospitals that are submitting data for this metric. There's only been 19 CLABSIs in the last quarter, so I think that's pretty remarkable and impressive commentary on the group that we've got working on this. And then we also track CLABSI ICU. It's showing an increased trend, but you can see here in the data, there's been a drop in the denominator and a bit of an increase in the numerator. And one issue to also note here are our hospitals have kind of taken a dip, especially in the most recent quarter. We've had a drop in some of the hospitals. Some of our smaller hospitals, we haven't been able to get data from those yet. So it's still a good comparison of the trend, but we are trying to get those numbers up. So just a reminder to those on the call or those data people that you may be in contact with, we have a data submission coming up on the 20th for the second quarter of 2014 data. And I hope that those on the call, if they are interested in seeing the comparative feedback reports that we provide based on the data you submit, are seeing those or have seen those. And if not, please let us know. Email us at admin@henlearner.org, and we'll connect you with the people in your organization or hospital that have those charts. We send those out within a couple weeks of receiving your data, so you can see comparisons of hospitals of similar bed size as your hospital, and then also comparisons of the overall HEN. So there'll be basically 3 rates on each of those comparative feedback reports. And that's for all metrics that you're submitting, not just CLABSI, obviously. So, again, if you haven't seen those and are interested, please email us at admin@henlearner.org, and we will get you connected with the person that can get those to you. I'm not going to spend a lot of time here. Just the metric definitions that we're collecting, PSI 7 and CLABSI in the ICU, they're pretty standard, NHSN and then PSI data. And then finally, we just wanted to celebrate some of the successes that we've had across the network. Looking at the PSI-7 rate, we have looked at the data we received, and note here the hospitals that have shown the most improvement from their baseline. Here, so you can see Denver, a couple of hospitals from Sutter, Espanola with the Presbyterian system in New Mexico, and then Baylor and Providence. And then we also just show a similar table that is looking specifically at the lowest rate. So there's a little bit of overlap here that you can see on a few of the hospitals, which is great to see that there are hospitals that are not only showing great improvement over the period that we've been measuring, but have been maintaining or have achieved some of the lowest rates within our network too. So congratulations to everybody that has been working on this and been making improvements in that area. And then again here in ICU, CLABSI's in the ICU. So quite a few Intermountain hospitals, Providence and Sutter, and it looks like in both those areas, Intermountain, Sutter, have been making some pretty big gains. So again, applaud those. Virtual pat on the back to everybody. And we like to celebrate those successes, and we actually have Marilee Brio here in the room with us, who has joined our team recently and is reaching out to some of the hospitals that are showing some successes like these, so we can get a little bit more detail and context around what's been going on. So with that, finally, we've got our Just One Thing matrix, which I hope others on the call are familiar with, which was outlined by our subject matter experts of 3 levels of interventions, what to do in working on these areas. We've done it for all the 10 areas we're focused on, but here we've got the recommendations that were made by our subject matter experts for CLABSI. That document's available on our website at www.henlearner.org, and we invite you to print it out and use it in whatever purposes best suit your needs. But it's been a real benefit for a lot of our hospitals that we've talked to in kind of distilling a lot of the information down into a simple one-page document of the initiatives that we're focused on and the recommended interventions that we're working to put into place. And so with that, we want to start. I'll turn the time over to Joan Golden, as I'm not high-performing there. A lot of the Intermountain healthcare hospitals have made some big gains in their work to reduce CLABSI. So I'll turn the time over to her to share how they've done that. So, Joan?
Thank you. First of all, I want to thank Jason and the Institute for the opportunity to present our project and our progress. The first objective is to acknowledge that Intermountain Healthcare has been recognized for patient safety, and I'll begin that shortly. And to describe the board goal process and its impetus. You'll notice that we've got a misspelling there, impetuous, which we're that too. So it works for both. Describe the implementation process at Intermountain Healthcare. So that was our third major reason for being here today. Okay, the next slide. Okay. We were recognized, Intermountain Healthcare was recognized for saving lives by the patient safety movement, and their goal is 0 preventable deaths by 2020. And they held a patient safety summit in California, and as you can see from the photos here, we've got some pretty influential people that were attending that summit. You can see past President Bill Clinton and others that were in attendance and recognizing 3 hospitals that were awarded for the humanitarian, Patient Safety Humanitarian Award. And we've got Baylor there, we've got Intermountain Healthcare and Mercy Hospital all being recognized. And for us, the recognition had to do with reducing CLABSIs. So, to begin with, we have over 14,000 patients had a central line in this particular year, 2013. Our infections were 63 infections, and I think this is an important data point. 43 lives were saved. And we've got the financial piece of it below, but I think the 43 lives saved is the one that really stands out as the reason why we're here, okay, and why we keep trying. And so, yeah, there was money invested in that period of time, and then there was a net benefit based on the lives saved. Okay, the major question that was asked to me is how did we implement this? Because you all know all the different rules, and there's toolkits of various kinds and so on and so forth, but the difficulty is getting people to participate and be engaged and this sort of thing. And for me, for us, and for Intermountain, it was because we set it as a board goal. Now, that goes to the top levels of our organization, our Intermountain Healthcare Board, and they choose a goal for every one of our clinical programs, patient safety being one of that category. And so they set the board goal of CLABSI reduction, and for this year, we carried over to sustaining either that lowering of the rates or even lowering them even more. So how did we do that? We had support from the top levels of the corporation. When you're talking about a board goal, you're talking about salaries, you're talking about engagement by everybody, and so it has a big impact on our entire organization. And everybody steps up to the plate and supports it 100%. And as I mentioned here, implications for performance evaluations are even affected. So it's quite lofty. Our goal was to attain a reduction in the system rate of primary CLABSIs for all inpatient patients, excluding BMT units and AML patients during the third quarter of 2013. Now note, it was for just one quarter that we set the goal. We developed, we calculated our baseline at 1.25 per 1,000 central line days, and then determined our goals, which would be an entry goal of 1.16, target of 1.02 or 6, and a stretch goal of 0.91. So these were what we were heading for. Now this is as a system. Our definition was the NHSN definition of CLABSI, and I'm sure all of you are familiar with that. And this included central lines in our, actually our rates were for not just ICUs, but for the whole facility. So unlike NHSN reporting of ICUs only, we had it for a system-wide, hospital-wide. Okay, and then our CLABSI rate was determined by the denominator is defined as total central line days according to NHSN standards, and that is that we count at 8 o'clock every day the number of lines that are in, regardless of patients, single patients who have more than one line. And so it's the CDC's way of calculating this, so we follow their guidelines for denominator. So one patient, one line count, one line day. Okay. Our next table here describes to you the numbers of the individual regions. We have 23 hospitals, and they're broken down into regions. And so the first ones you see here are the, region with primary children's. And then you have the rural region, which has some other facilities and so on and so forth. And so for these individual regions and facilities, we determined a baseline. And then underneath CLABSI there in the table at the second row down, for primary children's it says 41. That means at their baseline, they have 41 central line bloodstream infections. For them to move into the entry level, which would be 2.11 per 1,000 line days, would mean that they would have to drop 4 central line infections. So they move to 37. If you were to hit the target goal, they would have to drop to 33, and then to 29 if they were to reach the stretch goal. And that corresponds all along with our different regions and then by individual facilities. So the first thing we did is we took those regions, and there would be 5 regions in the state, and assigned a champion. And that champion would take the lead in organizing teams and working on progress improvement, process improvement, and that sort of thing. We also decided on champion physicians. And these are just a list of those physicians that were assigned to our individual regions. And of course, we had those at the central office leading, and Bert LePansry was our CLABSI subgroup chair, and Dr. Doug Smith was our Infection Control Guidance Council co-chair, and both of those physicians have been very much engaged in this whole process. So, just exactly what happened. We assigned these region champions, and they were selected by the CNO for the region. The region champions then provide leadership and oversight of the region, facilities, and units through existing region facility committees. We did not want them to have to create more committees and engage people in more time meeting together. So ask them to take current and existing committees and incorporate this whole process into that. They were to do a risk assessment gap analysis in each of the regions, and each month the region champion submits the report to the CLABSI subgroup, which is a subgroup of the Infection Control Guidance Council. And so we created a team space. We had them report every month of how they were doing and any barriers they might experience, so that if it was something that could be managed at the central office or needed to be bumped up to that level, we could be of assistance. So this is the example of the report that they would fill out on TeamSpace. And so we would give the particular month, the region champion action plans, barriers, and so on. And at the same time, we asked them to provide the contaminated culture rates for blood cultures, because we wanted to just keep an eye on a secondary data point that was related to central lines. And so we looked at that every month to see how they were doing. And towards the end of the presentation, I'll have some information of how we followed up on that. This is the report they got every month. So they had the system entry goal at the top, and they were reminded of what the entry goal, target goal, and stretch goal was every month. And then we would get a year-to-date results, which you don't see on here at this time because it didn't go out that far. But again, for January, our system rate was 1.17, and it's in the red. It's too high, okay? We have some region rates there that we have 0.38 for urban central region, which is in the green, which was looking good at that time. Okay, so every month that report was sent out so those teams would know exactly where they were at. Communication was very important to us, and we had communication conducted from the CLABSI subgroup and Infection Control Guidance Council to the CNO and the region champions. And we wanted to keep it centralized so that we didn't have people being called all over the place and getting, questions and this sort of thing coming from everywhere. So the communication to the regions and facilities and units came from that region champion then. So from the central office down to the CNO champion and then down to the facilities. And then the communication back was to follow the same pathway. Okay, so, and then I put, if all else fails, contact me. because I figure at some point something would fail. Okay, we provided them a resource packet, and then we provided reports available for them. Now, this resource packet, this is just a clip from there, and we've got the source of the reports and an explanation of those reports, and then links to how to get there. And we copied this from the resource packet that Marlene Conti put together for Falls. And so if any of you have been listening into her Falls HEN presentations, this copies her process completely. And in the resource packet, we had protocols and guidelines that we have here at Intermountain Healthcare and direct links to those. And so that was a resource to the champions and their teams where they could find what do we already have and what should we be doing according to that. Then we provided another set of links to the regulatory and recommendation agencies across the country so that they could go onto their web pages and learn more if they cared to do so. We had other resources in the packet. One of them is how to put a project together, how to organize it. Some people may or may not have had that experience, and so we provided that. Had them do an assessment and implementation and evaluation. This was all part of this project organization. So it walked them through all the steps of how to do that. And so we got started. I want you all to know that this was not photographed at any of Intermountain Healthcare's facilities, but you may have seen something like this. And so a good source of transmission for infection with that much going on. We did our gap analysis, and we looked at the issues before insertion. And so in that, we looked at indications. Does this patient really need this line? And we had the list of indications as provided by your regulatory agencies. Competence, does the inserter have privileges to do this? Assess the patient, the coagulation status, allergy to heparin or latex, number of things that we're looking for. Supplies, did you have the insertion bundle kit at the bedside, which we have all the supplies that we need for a proper insertion. Informed consent and patient fact sheet. We want to be able to teach the patient how to prevent infection and tell them what we're doing to prevent infection. And then the timeout procedure to focus on that. Make sure you've got the right patient and so on. Again, with the insertion site, we looked at subclavian site versus other choices, and subclavian being the lowest risk, internal jugular site being the next best, and then we have our PICC line nurses involved, and so we have peripherally inserted CVCs, and then the femoral site being the poorest risk, and would encourage them to remove that and reinsert at a less risky spot. Our gap analysis included the insertion bundle, and so we have ways of electronically charting this, and so we looked at compliance to all of these factors. We had, for your hand hygiene, mask, cap, gown, gloves, so on, skin prep, and protective garb for those in the room who are closest to the insertion site. We have a door sign, which one of our facilities created a big stop sign that said do not enter, and that was in an effort to control traffic. Sterile technique and bundle compliance to the checklist. So we looked at all of that in terms of the insertion bundle. Now, then we started looking at line maintenance options. We have CHG impregnated dressings, which we have implemented and standardized at this point. We looked into alcohol caps, which go on the ports, and those have also been implemented not only on central lines, but as well on peripheral lines. One of our, our lead, Bert Lepanstre, Dr. Bert Lepanstre, was adamant at the beginning of the year that we needed to look at peripheral line infections and see what we could do there. And that's how we came to use the alcohol caps on those two. And there's literature out there that talks about peripheral lines being a source. We had CHG washcloths and daily assessment of ongoing need for the central line. So we had doctors and nurses conditioned to ask that question every day in doing their rounds. We had dressing change and site care every 7 days, and then, of course, more frequently if needed. Okay. Some other things that we did was we had strict adherence to the insertion bundle documentation and line maintenance processes. We have a speak up if you observe discrepancies or breaks in sterile technique. We want to encourage staff to say, stop. You know, somebody just broke technique, and we need to do something different here. And then support from local and regional champions. Consider a concurrent huddle, a mini RCA. These were started in some of our facilities and then spread throughout, which if they had a CLABSI, all things stopped. And they would have the physician, the nurses, and anyone else taking a look at that case to see what could we have done differently, maybe to have prevented this. And we did have a couple of newborn ICU cases that were, if you did an RCA on those, you would come out saying that they were extremely high risk. And you could have done everything, and you probably still would have had an infection with these infants who were 22, 23 weeks, that kind of thing. And then we emphasized personal responsibility. And so, and as I said, the goal was corporate-wide, and so to get people to take personal responsibility was just expected because of the loftiness of the goal. Okay, this particular picture just, again, is not found in Intermountain, but it was something to think about. We incorporated the alcohol caps, but we also recommend, if they don't have the caps, that they do the scrub for 15 seconds and to prevent that sort of thing. Okay, and this slide was supposed to be removed from the presentation, so we'll just get rid of it now. And this is our alcohol caps as they hang on the IV pole, and they're ready to use. Kind of a good reminder to nurses that, you know, put them on. There's some things that we did with our central line insertion checklist. We looked at it very closely, and we made some changes. We added fields, for example, of count of guide wires. Wanted to make sure that we had the counts together at the end of the procedure, and indicated whether or not this was a reinsertion. So with that kind of information, we could look at infections in a little bit more detail. There was an algorithm developed in one of our facilities to minimize the number of lumens. Recommended that the fewer lumens you use, the less risk. And we collaborated with IS for improved charting of the central line checklist elements, which we have had great success with our IT people to make that available to us so that when we go to query information, it's really easy to get compliance data. We re-educated on the use of the maximum barrier, and we also determined how the checklist would be used in the region. We left it open for them to use it as just educational or to use it at the bedside. or retain documentation for the infection preventionist. Certain elements were in the charting. So electronically we had parts of it, but we also had the hard copy that they could keep as a checklist by the bedside, much like your airline pilots do. Okay. The interventions, which we've mentioned a few already, but the daily rounding, I think, is extremely helpful, where all the parties taking care of this particular patient are looking at a number of things, but they're asking about medical necessity of having this in, because the sooner you get it out, the better. And then the huddles. And I described that already, that they would do intense review of the particular cases. There was frequent rounding to audit practices, and that is still ongoing, having to do with the alcohol caps. And they had monthly multidiscipline roundtable meetings to analyze their data and develop action plans for improvement. And I've attended some of these. Very impressive. You had from your CNOs down to staff nursing and other caregivers sitting around the table discussing the individual cases and giving input as to how they might improve processes. And then they, at the same time, they also looked at hand hygiene rates. And so if they're making some sort of a correlation there. We minimized the traffic going into the room, and as I said, we developed a sign that would caution people to not enter because a procedure was being done. And we empowered the staff, as I said, personal responsibility to stop the procedure in the event of a break of sterile technique. And I don't know if that needed to be done or not. We've never gotten reports back, but they had the authority to do that if it became necessary. But this particular report follows our central line bloodstream infections, and this is for system-wide, and it is also for house-wide. So it's not just the ICUs that we're reporting to NHSN, but this is all of them. And in 2010, the National Patient Safety Goal came out, and we started going through all their different elements of performance and identified for all of our facilities what they should be doing and resources to get further information and process improvement. So that started in 2010, and that's our very uppermost line. And the line that's the most impressive in this particular report and that I like is that they do an annual average, annual mean. And that green line is that. So you can see it's dropping as time goes on. And so then we added the central line bundle charting. That made a difference. And then we had the patient safety goal decision to implement, just a decision to implement and not go live, caused some changes to our rates. And then we had the implementation of alcohol caps, daily assessment, and case review, and then go live date for the goal. And then you see a nice big drop. And if we had this kind of report today for 2014, we would see another drop. So it's looking really good. This was at the end of the year for 2013. Again, the system rate. And so the measurement period was in the yellow here at the end. It's at 1.12, and it's July, August, and September, which you see are in yellow as well. And we made it under the entry goal, but not quite to the target. And so we planned on doing maintenance or sustainability after this 2013 year, but with these kinds of numbers, we for sure we're going to go for lower rates, not just sustainability. Okay, so that's where we're at now, is reducing our numbers even more. So this is processes that was developed by our infusion guidance team. And I've got Karen Bronson here who leads that team. And if you have any questions about this, feel free to ask those now or at the end of the presentation. But it's centered around aspiration of blood from the central line. And so they require aspiration of blood every 12 hours on all central lines that had not been in continual use. Required removal of occlusion for any central line that would not aspirate blood. And then it clarifies that by saying, even if the line flushed, if the blood could not be aspirated, removal of the occlusion was required. They educated nursing and staff regarding reasons for the occlusion. And then we had specially trained staff to do occlusion removal with associated skill pass-offs. So we had experts in occlusion removal. Now, I put in red there because this was something that was significant. Home care had been telling us for quite some time that patients were coming home with clotted lines. And in the home care setting, that's hard. And so with all of these improvement processes put into place, led by the nursing group, we now are friends again with home care. So they were very happy with the results of that. We educated regarding scrubbing the hub, as I said before, but we also have implemented the alcohol caps. We also educated nursing about current events in our system when needleless connectors had been left off of the central line hub, leaving the catheter open and at risk, and educated about portacath access as well, so it's included in the education. We focus on dressings and standardize the dressing change frequency. And that's been an interesting ongoing process, but we do it every 7 days. The day of the week is still under.
We had several facilities that did a specific day of the week, but we're just moving to a standardized system-wide day of the week. We're just making some final decisions.
Okay. Some wanted to do it Thursday, some wanted to do it Sunday. So Karen's been working with him to figure out a day that works for everybody. They assigned the PIC nurses to evaluate dressings, which I think is really a good thing to have those nurses go around the facility and make sure everything is cool. And then we standardized the CHG central line patch. This particular slide is there because it shows the sutures and no patch, but we've discouraged sutures. Do we have anybody using sutures now?
We do. We still have a few, but we are asking that, we do have some facilities that use securement devices, but we are in the midst of a couple more trials of some securement devices and hope to get a standardized use of those soon.
Did you want to elaborate on those sutures? Those securement devices?
We trialed the 3M PIC CDC securement device and had good results from that. They feel like it's a high learning curve for the staff, but once it's on, it's a really great device. Primary Children's is trialing a securement device at this time called the Incitra Modulaire, and we're expecting a report back from them this month in our infusion guidance meeting. So it's our hope to get away from suturing wherever we can. We know there'll be patients that will always need sutures, especially in the pediatric population, but we're going to try to move away from them as much as we can everywhere else.
Okay. And that is Karen's group, again, of nursing that works toward those improvement processes and continues to look for ways of doing even better. We had a hospital that was piloting the CHG bathing, and as I've looked out on different studies that have been done, CHG bathing seems to be a big part of their processes. So we did not do that system-wide, but had a facility doing that currently and waiting to hear how that turns out. And as I told you before, we were looking at contaminated blood cultures because we felt like we had a high rate. And so we educated for proper blood culture technique and put in all of our documents that it was preferred to take your culture from a peripheral line rather than the central line. And we had Bert Lepanstri, again, our MD lead, talked about a case to us where the blood culture was taken from the central line. It was contamination from somewhere, maybe the central line, I don't know, but the patient was treated for an infection when, in fact, when they took cultures from the peripheral lines, there was nothing. So basically his premise is you might treat somebody for infection when indeed they are not. And so the preferred, again, is from a peripheral line. And that's difficult because nurses don't want to keep sticking patients, you know, and patients don't want to be stuck a lot. And so that's a big deal. It's hard for nurses to stick someone when they just go straight to the central line. But in the long run, being better for them to go to peripheral. Okay, one of the things that we improved for this year over our reporting process for 2013 was that our measurement period went to 6 months instead of 3. And we had a couple of hospitals asking for that and saying this is one of our barriers. You know, if you went over a longer period of time, our rates would look better. But if we go for 3 months, we might just have a very bad month and our rate looks crappy. So we've extended it to 6 months, and people are happy about that. At the time of this, that I put this presentation together, our current rate was 0.74. So, and you remember our rate before was 1.12. Okay, so it dropped considerably. And our target rate is 1.06, so we're below target. And we're also below the stretch, which is 0.91. So 7.4 looks darn good. And this is how that report looks. A lot of green across there. And the yellow for the 6-month period was not completed on this report, so apologize for that. It should have been July through December 31st. So, okay. If you have questions, we would welcome those. And as I said, I've got Karen Bronson here, who's the lead over the nursing group, who did a lot of the audits and the product implementation and process changes and this kind of thing. So she's here for those kinds of questions.
Great, thanks, Joan. So the lines for the participants have been muted, but Amanda, if you could unmute the participant lines so we can get any questions over the phone that we may have.
Yeah, let me do that. I think it's been done. Let me confirm. Everybody should be unmuted here. Yeah,
okay.
Everyone should be on the line at this point.
Great. So we'll pause for just a minute, and if anybody does have any questions, go ahead and speak up. Or comments. I'm not seeing any comments or questions that were entered in the chat box, but Amanda, if you may look through.
I'm not seeing any either.
Okay. Great. Well, if people are thinking about, I have a few questions for you, kind of working back. So you meant one of the things you mentioned were the, you know, moving away from the draws from the central line and doing peripheral sticks. is that part of the patient education that you provide to the patients up front, explaining the risks associated with blood draws?
We did not.
Okay.
But that's a dang good idea. Yeah, I really do. In fact, that's something we ought to add to our fact sheet so that the patient also knows that we ought to be doing it from a peripheral line and not the central line, and so if the nurse is wondering, the patient can speak up. Okay. So, thank you.
Okay, good. Well, one of the focuses along, the overall arching focus of the HEN in working on these 10 patient safety areas is patient and family engagement. So there's always, education is one of those things. So good to have education is being provided. Another question I had about the CHG bathing that's being piloted, at least in one of the hospitals. Are you monitoring that just specifically for its result or its effect on CLABSI reduction, or are you monitoring other infections?
Actually, I believe the CHG came out initially with a recommendation to prevent CAUTIs, and it just makes sense to prevent CLABSIs as well. And so we would be monitoring all of our infections out of those units that are doing this to see if it makes any changes.
Okay.
So.
Well, I know there's been a lot of talk with some of the other infection groups that CAUTI.
Yeah.
So,
yeah.
Great. It looks like we did have a question in the chat box from one of our participants. I'm not sure from who, but the question is, with the mini RCAs, were the CLABSI cases from that day or a different time frame?
It was that day when the nurse, when the IP identified it. So when she got the cultures or whatever criteria she was using, I mean, she could have been making rounds and discovered the patient had fever and this kind of thing, and then not necessarily a culture. But it would be that day if possible, if not the very next day, and the patient would certainly still be there. So it was as concurrent as possible. Okay. So it wasn't like having to go back in time and research charts that the patient had already recovered and left, that kind of thing.
Okay. Excellent. There is another question in the chat box. What were your sources of evidence related to drawing blood every 8 to 12 hours in preventing CLABSI? Is that a CDC recommendation? If it is, please share where to find guidelines.
That would be a Karen question.
I would have to get that reference for you, and I do have it, but not off the top of my head.
Okay.
Every 12 hours we aspirated blood from all unused central lines. And I do have references for that, but I'll have to get that.
Okay, so Karen and I will follow up and we'll share
I'm
that
not
reference.
sure if the exact 12-hour thing was a specific, guideline. We just came to that decision as an infusion guidance team because our shifts are generally 12 hours, and we thought that at least once per shift someone needed to aspirate blood from that line. But I will look up the reference for the other. We had a reference from the CDC and INS. I think it was INS was our main reference, stating that the fibrin plug that occurs during insertion of a PICC line can be a great source of infection. And so when that fibrin plug gets in there, sometimes you can instill NS into a central line, but if you can't aspirate blood, we decided that we would have the occlusion removal done because it could be that little fibrin plug, and that's a great source for microbes to grow. I believe it was the INS, but I will get that reference for you to share.
Great. And we'll share that with the group when we get that, along with when we have the link of this webinar available, we'll share this source as well. So another question, can you share your algorithm for the number of lumens?
Probably, yeah.
Okay, so we'll include that as well.
Yeah.
Great question. So another one, would you be willing to share the criteria for early identification of CLABSI cases as our actual verified cases are about 30 days after the fact?
So they're thinking that you can't verify anything until 30 days out?
That's what it's looking like. I'm wondering, I'm not sure who asked this question, but if you're still on the line, could you help us clarify the points of this?
This is my understanding that our identification was as concurrent as it is to get a culture report back. And that's while the patient's there and not 30 days out. So I'm not sure what the dilemma is.
Okay. It looks, Kathleen Shuey, are you able to connect? Well,
Calling in.
oh, okay. She's calling in. Okay,
While you're waiting, I'm sorry, I didn't mean to interrupt
No.
you. I do have a couple of updates to our sustainability plan. As we presented the CHG impregnated disc to a lot of our system-wide teams, critical care, med-surg, our nursing practice teams, you know, they wanted us to help them with compliance for use for this CHG disc. So what we've done is we have created a dressing change kit, a central line dressing change kit that actually has the disc in it. And we felt like if the disc was there and they saw it and they didn't have to go get a separate thing, that they would be, you know, more compliant to use it. We've also placed the CHG impregnated disc in the PICC insertion trays that we have. And our next step now is to work with our supply chain organization and the individual companies that we've purchased other types of central line dressing change insertion kits from to have that disc placed in those as well, so that the kit will be all-inclusive for everything you need, and the disc will be there, and they'll put it on at insertion. And then they are placed on all dressing changes. We've even been approached now by the critical care team. They want to start using them on art lines. We didn't initially ask for that to be implemented, but they are seeing a value in it. And then we also have tube and drain folks that want to start to use those CHG discs as well. So it's sort of started a great practice for decrease of infection in our system.
It looks, sorry if I can interrupt real quick. It looks like we may have Kathleen on the line now. Kathleen, are you on the phone?
Yes, I am.
Great.
Can you hear me?
Yes, we can.
So the reason I said 30 days, we get our report back from epidemiology. It takes anywhere from 30 to 45 days before we see the report with the CLABSI on it. If I'm looking at number of positive cultures is a large number, and not all positive cultures are actually CLABSI. And I will clarify, I do work in oncology. So we have a large number of positive cultures coming back, but not all of those patients, and very few patients end up on the CLABSI report. So we're looking at those cases 2 months after they've happened to evaluate what went on. So I was wondering, if you're identifying your CLABSI within 24 hours, how are you doing that?
Okay, it sounds like you have a CLABSI report that's every 30 days, right?
Yes.
Okay, and we have that as well, which is some of the reports that I just showed you today. Those come out every 30 days that go to the facilities and so on. But
we have a, if I can just interrupt for a second, we have a lag time. I just got the May-June report, and we're in August.
Okay.
So they are 30-day reports, but they are coming out with a significant lag time. Okay, sorry.
Yeah, I understand that. And if you're depending on that report alone, I would say, yeah, that's 30 days out, and that's problematic to have a huddle right at the time. But our IPs are getting positive cultures immediately emailed to them from the lab, and so they have that right away, and they look into the whole case to decide or see if it is a potential CLABSI, and then look at the case right then and there. So they are not waiting for any monthly report that comes out.
And who is the group that's looking at that? Your epidemiology group?
It's our infection prevention.
Your infection prevention group, okay.
Yeah, and they're, and see, there's a problem too, because we send out our reports every month, like you say, to our champions, and they may have discovered somebody in May. Well, that's been a while. To do a huddle or a look at that is going to be a little bit more difficult because you're going to have to depend on charting to get your answers. But we have reporting that's going to our infection preventionists concurrently. And so they're able to identify either confirmed or potential CLABSI patients very quickly and can conduct these huddles.
And how many infection preventionists do you have? Sorry.
We have 23 hospitals, 22 hospitals, and we have approximately that many infection preventionists as well. We have a few facilities that have more than one, and we have some facilities that are combined, say 2 hospitals to 1 IP.
Okay, thanks.
Mm-hmm.
So basically the summary there's been an established protocol when a infection or a potential infection is established in the lab, the protocol is to immediately alert that IP.
Right, and we have an interesting system with Intermountain. We have informatics epidemiologist Scott Evans, who has created screening programs for us that are over 20 years old in the system that screen for certain things, and if they meet the criteria, then they're shot off in a report. And each day they're sent to the IP at like 12 o'clock in noon. Okay, and also we have an HAI database, which is an electronic database that gets populated by some of those that are picked up by his program, and then so an infection control nurse can go to that and either confirm or disqualify an infection that has been loaded based on the criteria that he has set, because it might be meeting that criteria, but it may not meet all criteria for a CLABSI. On the other hand, it may have identified a case that IP may have never found out about because of certain things, certain flaws in the system.
Okay. Thank you.
You betcha.
Great. Thanks, Kathleen, for the question. It looks like we don't have any other questions in the chat box, and it looks like we have just a couple minutes left. I wanted to just touch on an issue about one of the questions with the mini RCAs, and you know, you had established basically kind of this high reliability or the culture of safety with the staff as well of, you know, speaking up, being empowered to speak up, and then also taking responsibility for that. Can you kind of explain what taking responsibility for these CLABSIs means for the frontline staff? Is it a disciplinary approach, or is it a learning sort of approach?
It's not a disciplinary approach. It is definitely a learning. And because everybody's involved, you want to be involved as well. And so it's kind of a peer thing as well. So I think there's a lot of factors that play into it. How about you, Karen? You have anything?
I think another thing to consider is that empowering a nurse to speak up when a physician is placing a line and he or she sees that there's been a compromise in sterile technique, to be able to say, hey, Dr. Smith, you know, you just accidentally, your line ran across the bed rail, or, you know, being empowered to speak up and say, we probably better get a new kit and start again. Mm-hmm. Just letting them know it's okay if you see it, say something.
Yeah, I agree, definitely.
Great, thanks. It looks like if we have time, we may go over, but if we have time, Mallory, sorry, I don't.
Yeah, it's pretty terrible. Mallory Pyshak, I'm from Baylor McKinney in Texas. So I have just a couple quick questions. So when y'all do y'all see a high incidence of PICC lines versus subclavians, or which one is a higher incidence for your, I guess, system?
I don't know.
For CLABSI?
Are you just talking about
just the rate of PICC
for line usage? We use a lot of PICC lines here, and so
I would say PICC higher. We have a high rate of PICCs because we put them in for, we have a lot of outpatient infusion clinics, so if the patient starts an inpatient there, it's placed there. But I would say we probably have a higher rate of PICCs.
Okay, awesome. We're similar here also. And then one more, I know we're out of time, but as for your, the way you're using your alcohol caps, are you just putting them on the ports of the IV or your central lines, or are you also putting them on the access points for your lines?
Okay, here's what we educated, and we had a painful push for this, but we've placed them on all unused needleless connectors, on all peripheral, that's central and peripheral, and then on IV tubing. So if you have an antibiotic that's Q6 and you've got the tubing there, there's an end cap, and then some tubing has 3 access ports. We want to cap on every single access port, the end. The company that we went with did a lot of studies, and they found the greatest colonization of microbes was on the end of the IV tubing itself. So while we've made great improvements with our alcohol cap compliance, I still see reluctance of the staff to get those on the peripheral lines and
all the caps.
And on the tubing.
No, actually on the let's say you have a peripheral line that has that's capped off. We want them to put them on those needle connectors as well. They're great about the central lines because they have it in their mind that that's the biggest risk, but we want them on the peripheral lines as well. We have pretty good compliance, I think about 89% right now on IV tubing, but our peripheral lines is still in the low, about 80%. So we have great compliance in the 90s on our central lines, everything for those.
Well, thank you very much.
You're welcome.
All right, thanks, Mallory. Are there any last-minute questions? Okay, well, we'll wrap up. Thanks for the presentation. It was helpful, and thanks all for the questions and participation. If any questions come up as you review this or think about it, please feel free to email us, admin@henlearner.org. And like I said, we'll be sharing those guidelines as well as the algorithm for the Lumen.
I sent you that evidence.
Oh, okay, great. So
central line management evidence.
Great, so that'll be going out shortly. Actually, I'll send it all out as a bundle when we have these slides posted along with the recording. I'll just send it all out as a bundle so it's all together. So thanks again, everybody, and have a great day.
Good job.
Thanks.